Okay, so we're going to go over the chapter on gastroenterology. If you have the other version of the book and it's not chapter 34, it's still going to be the same information. They just kind of rearrange the chapters and stuff, so don't worry if you're like, oh, this is not my chapter 34. So anyways, just make sure you are looking at the chapter for gastroenterology, and we're going to start on this first slide here. So I'm not going to just read off everything on the slide. I'm going to talk a little bit about, pertaining to each slide, some information, because I know you guys can go back through and, read the PowerPoint. You don't need me to read it to you. So I'm just going to talk about a few things. But in here, so the anatomy of the GI system, this one I am going to kind of read off because there's not much else to kind of go through. But of course, so you have the digestive tract, which is going to be your mouth, pharynx, which is your throat, your esophagus, which then leads down into your stomach, and then the small intestines, and then the large intestines. And then you also have the salivary glands, which basically help to it's going to help the breakdown of food, but make it easier for you to swallow. And then your gallbladder and liver and pancreas, which will help kind of filter out, some things and absorb some things that we do need from foods. So, all right. So of course here, whoopsies, move that a little bit. So, of course it starts in your mouth here, then the pharynx, throat, and then down into your stomach and everything. So, okay. So, and the stomach just is where it holds the food until it goes through, the small intestine. So in here, whoops, there's my mouse. So your small intestines are in here, and then the large intestines is kind of what like wraps around it. So your small intestines, as when you eat something and it goes into your stomach and it's being held there, where inside your stomach it's gonna break down the food with some digestive enzymes, and then it will go into anything it doesn't need, any waste or anything is going to first start in your small intestines, where that's going to help to absorb any nutrients as well. And then it's going to go into the large intestines, where you then have whatever, the waste is. So, and you can kind of see how that moves through your body. So it starts on the left side, or I'm sorry, it starts on the right side and then goes up and above and then to down, basically down. So it kind of wraps around the small intestines there. And your small intestines is pretty dang long. So, and then here is, we have our large intestines. So this is where that final process happens, where then, whatever waste we have then goes through the large intestines. Yes.
So in the last slide, you have the stomach and small intestines.
This one?
It's the small intestines that help absorb nutrition, or what is it?
So the small intestines, like that is while your body, so it goes through your stomach to digest. So the digestive enzymes are kind of breaking down the food, and then it goes into your small intestines, where it helps to absorb like water and then some of the nutrients. But then your liver, your gallbladder, your pancreas, those help filter out and absorb other things too. So your small intestines are then basically just taking anything left over that it could possibly absorb, mostly like water. So, but it's not the main area where it's absorbed. It just is another area where it's like, hey, this is the final stage where like anything left over, your body might absorb it. And then it goes into the large intestines, where it's like, okay, all of this stuff we don't need, so let's get rid of it. Okay, and then this is a better picture to show you your digestive tract, or basically the whole GI system. So, so again, of course, everything, when we eat something, it goes through the mouth and then down into your esophagus, into your stomach and whatnot. But I wanted to make sure you guys know that the liver and the gallbladder are also parts of the digestive system. And so a gastroenterologist will also see patients who have issues with their liver, which will go over certain diseases and disorders of the liver, as well as your gallbladder. So I wanted to make sure you guys were aware of that. Oh, I'm sorry, and your pancreas. I wanted to mention that as well. So it's not just, your stomach and then your intestines. It's, all of those plus liver, gallbladder, and pancreas. So, and if you look through here, it'll tell you actually, there's a breakdown of what each thing does. So the small intestines emulsifies fat, the pancreatic secretions, intestinal secretions. So basically anything that the pancreas and your intestines, like secretes, that's gonna absorb those nutrients. So it's gonna digest the fat, protein, and carbohydrate part of whatever food was processed. Does that make sense? Okay, next one. All right, so our salivary glands, of course, so those are going to help us when we are eating any foods. They are going to help. That's like the first part of the digestive process. So the salivary glands actually start to help break down the food. But mostly it's there, it helps us to swallow because it's, if you have something really, really dry, obviously it's going to be really hard to chew and swallow. So, but that is the first process here. So your liver is a pretty big organ right over here under the right-hand side. So underneath your ribs there. And I'm going to show you guys some things. Oops, and I didn't realize I covered part of the picture here. So I'm going to move that for you guys at a different time, but yeah, sorry about that. Okay, and then your pancreas, which I showed in the other, that other slide where it had the structure and anatomy basically, is a lot better picture than this here. But this is another picture to kind of show you how this looks. So your liver is really big. And then your stomach is about half the size of your liver. Your stomach really can hold about, a fist-size amount of food. Of course, though, we can stretch out our stomachs by eating too much and whatnot. So, but your stomach should be about the size of the fist, at about half the size of your liver. Okay, so some common signs and symptoms of gastrointestinal issues. So this is the types of things that we would want to ask patients, like when they call in for stomach pain, or they could say they have a certain like lower abdominal pain, upper right hand abdominal pain. We want to make sure we get as much information as possible, but some common symptoms that a patient might have, constipation, diarrhea, heartburn, indigestion, gas, vomiting, and then the yellow coloring of the skin's jaundice, that they would either would need to go see your gastroenterologist right away, or depending on how bad it is, if it's something that is a sudden onset, they would end up going to the emergency room, and we'll go over that a little bit here in a few minutes. But so you'd want to ask them to how long this has been going on for, and then if they've noticed any bloody stools, and then if they've had a fever at all too. And we want to ask them where the pain is if they are having pain. Sometimes they don't have pain and they just have, one of these symptoms, but they don't have any specific pain in a certain area. That kind of helps tell us what the issue is. Because if they're having pain in their upper right abdominal area, then it could be either their gallbladder or their liver. So, of course, we can't diagnose that, but it kind of helps us to know what could potentially be going on. Okay, so hernias. There are different types of hernias, but one of the one that a gastroenterologist specifically would be seeing is what's called a hiatal hernia. So this, if you kind of picture above this area, this would be your diaphragm here. So basically it's where part of the stomach goes through the diaphragm. And this is a very weird thing that happens. And I was trying to find the picture of an x-ray that actually had where their entire intestines went up into their diaphragm. It was really weird. But I don't know, no one knows why, but there can be a sudden rupture of the diaphragm where then your intestines move up into your chest cavity. They don't know why that happens. I'm not saying that's something that's going to happen to you guys or anything. That's like a really extremely rare thing that happens. So don't freak out and think like, oh, I can suddenly have my diaphragm rupture and then my internal organs are all in my chest. don't worry. That's not something that happens very often or anything. And if it does, it's usually just a very tiny portion, and they'll do a x-ray to see exactly, how severe it is. And then usually, we'll do surgery to fix it. So, and then they'll put like a little mesh, it's like a mesh type thing. Oop, having issues with flowbacks. Uh-oh. Okay. I just want to open up the chat thing too, in case you guys have questions. Okay. But yeah, anyways, they'll put this mesh material over that opening so that way it doesn't just slip back in there again. So, all right, so ulcers are pretty common for people to get. A lot of times this is caused by stress. That's the most common thing, but also depending on what the person's diet is. So certain, like drinking too much alcohol, eating acidic foods, or like really spicy foods, taking too much aspirin or NSAIDs, those can cause that as well, because you don't want, those types of medications should be a as needed type thing, not a daily, like a regular dose medication, like they're taking it, hold on, let me let her in. But they shouldn't be taking it like a regular routine pill, like, where it says on there you can take it every 6 to 8 hours. I mean, that's it when you need it. It's not like a regular, like you need to take this daily type thing. So that can cause an increased risk for them to get an ulcer as well. And again, like I said, stress is a big cause of getting an ulcer. And certain radiation treatments, and then of course smoking is going to be another risk factor for ulcers. And that can also be an ulcer like in the esophagus as well. So a lot of times this person will have a lot of stomach pain or pain when their stomach is empty, and then also might have some acid reflux or heartburn with this. But they'll usually have pain in their stomach, and then if they do, like say they eat spicy foods, and that's something that causes their ulcer, that will actually make it even worse. So when they do eat those foods, they'll be in even more pain. So these symptoms, yeah, I mean, so yeah, stress is a big factor in ulcers.
Is it fast to let it just go?
It can be. Sometimes they can heal on their own if you just kind of
Eat healthy.
Yeah, like a doctor might suggest, like a diet like the brat diet that's like a very plain, yes, a brat diet is bananas, rice, applesauce, and toast. So like really bland foods that aren't going to cause any irritation. Because sometimes that will just, it'll fix it. But depending on how big it is, how severe it is, they may have to do surgery. Not very often that's something that happens, because they can usually do certain treatments for it.
Common in everyone, or is it like a more?
I mean, anyone can get it. It is a pretty common thing that does happen. But it is, I mean, it's easily treated. Okay. I don't know. Did I skip a slide? No, okay. All right. So just in case you guys were not aware, stenosis, anything that says stenosis means a narrowing of something. So what this is, the pyloric or pylorus, is an opening between the stomach and the small intestine. So it's a narrowing. Whoop. I think we're having some WebEx issues. But anyways, this will be recorded for them too. But so anyways, that's a narrowing of that opening. And it occurs more often in males. Not exactly sure why it's more common in males than it is females. And it happens a lot for younger infants. So lots of the signs and symptoms are going to be, you know, like lots of vomiting. Sometimes they could be more hungry more often. Issues with weight, vomiting, dehydration, burping a lot. So, you know, little babies that have that where like they'll eat and then they'll just instantly kind of like throw it back up, that could be because they have that narrowing between their stomach and their small intestines. So like if when they eat something or drink something and then it just comes right back up, it could be because there is just, you know, this small area where that can pass through and then it just kind of comes back up because there's too much to be able to go down that drain. So if you think of it as like a pipe, and you have a pipe that is like this big, but you have like an amount of fluid that's like this big, and it's trying to go through there, and then everything kind of keeps coming, it's going to eventually back up. So if that does that make sense?
Explain that one more time. So you back up, is it common? Does it cause me to vomit?
I mean, usually.
Or is it something that happens when you vomit?
Well, it's something that happens. So if you have that narrowing there, and you know they eat something and then they keep feeding, it's eventually just going to basically back up. So because it can't, it's like you have, you know, a bunch of fluid that's trying to go down a very small opening, and if you just keep adding to it, then eventually it's just going to back up because you can't drain that fast. So
treatments like surgery?
Potentially. That would be like the worst case scenario.
Like medication?
I'm not exactly sure what all the treatments are that they do. I know that they do try to like have more frequent feeding times. So, and then like a smaller amount of formula. So instead of like the normal amount that they would do, you know, however many ounces it is, say that they are supposed to have like 4 ounces every couple hours. Instead of doing that, they may do like 1 ounce over the course of that 2 hours, or the 4 ounces over that course of the 2 hours, but like broken apart. So it's like, you know, this hour you're going to do 1 ounce, and then a half hour later you're going to do the second ounce, and then a third 30 minutes from that mark, then you do the next, you know, kind of breaking up so that way it's not constantly trying to go through this small area.
Does it say when it's most commonly in males, male infants?
Male infants. I'm not exactly sure why babies are more likely to have this. Babies are more prone to certain things, mostly because their bodies are still kind of developing. So it could just be because, you know, when they're younger at 6 months, their body is not, I mean, of course you still grow and everything. So, but certain areas are not fully developed still. So it might be something to do with that. Between the small intestines and the stomach. So, yes. Yeah, maybe. But that's too, like, infants, you know, when they're born, their lungs are still not completely developed. And that's sometimes why there's that sudden infant death syndrome where they just kind of stop breathing. So, which is, this is completely unrelated, sorry. But they now have something that's like a little monitor you put on a baby that will like alert you if they've stopped breathing. Because most of the time, like if you pick them up and kind of like blow in their face or, whatnot, kind of rub their chest, then they kind of, start breathing again. So, but their bodies are still developing. And of course, you still develop, throughout your life, and go through puberty and stuff. And then you're always continuing to develop. But usually when you're under that age, there's more things that are still in the process. So, okie dokie. That's out of the way. Okay, so celiac disease is an autoimmune disorder. So a lot of times with this, someone could eat anything and it could trigger their celiac disease, but gluten and dairy are two of the main things that cause people to have flare-ups. But also stress can cause flare-ups for people with celiac disease too. So depending on how severe it is, they may start them on Humira, which is an injectable monthly treatment. But a lot of times though, like other signs and symptoms could be issues with their skin. They might have sores in their mouth. So that could be another thing that's causing, or another sign of the celiac disease too. So of course they're going to need to be seen by a provider and have some testing done. So that way they can determine, if it is actually celiac disease. Next slide. All right, and then diverticulitis. So the difference between celiac disease and diverticulitis is that diverticulitis is not a chronic condition. This is just a inflammation of the large intestines, and where you have these kind of small little marbly sized pouches inside and outside the large intestines. Most of the time this happens to people like, low fiber diets, high fat intake, lack of exercise, smoking. This, depending on how severe this is, they might just give them like some Pepcid, and then put them on a diet, kind of like that brat diet where, there's pretty much bland food that's not really gonna irritate anything. So that's what they'll usually do for a patient, most of the time just having rice, making sure that they're not putting any dairy, butter, things like that in their foods, so that way they can help get under control. So sometimes it's just as simple as changing your diet and then, it cures itself, but then there's other times where it doesn't, and then there's some medications that they might give to that patient along with changing their diet. So irregardless, they still will need to change their diet for a certain length of time, depending on their severity. That's going to, determine how long they need to do that. A lot of times it's just based off their symptoms. If they still have the symptoms, continue doing the diet, even if it's, the 10-day mark that we suggested or something. So, but it's not a chronic thing. It's an acute issue. So, I'm in a lesson. So, all right. So of course we know that there's foodborne illnesses. So, you can get food poisoning, and that can come from various issues, but the ones that we would be more concerned about are all of these types of illnesses. Not super common, but when someone has, foodborne illness where they did have, my throat is really dry, sorry, where they did have like food poisoning, if it's something that doesn't resolve right away, because usually that would, food poisoning is caused by so many different things. It could be that they just left something out for too long, or they cooked foods basically that were past the expiration date and stuff. So, oh yeah, you can add foods back in eventually too. It's not permanent. But yeah, if someone continues to have issues with like nausea, vomiting, fever, fatigue, headache, sore muscles, the doctor would then want to see the patient, and then we can do different testing for these, which usually involves stool testing. So, and I'm sure you guys know what hemorrhoids are, which are the swollen veins that are either, they can be external or internal. So swollen veins around the anus or the lining of the anus and rectum. So just enlarged veins there. Okay, these are the different types of hernias. Yes, sir. You got a question?
Is it painful passing?
What?
Yeah, painful.
Oh, yeah. Absolutely. Yeah, if you have a hernia, or wait, a hernia or hemorrhoid? Yes, if you have a hemorrhoid, it's definitely painful to have a bowel movement. And a lot of times they'll like have blood, so they want to they're not quite sure if it's blood in their stool. But if they know they have a hemorrhoid, then they usually know that, it's either draining. But a lot of times it's caused from like constipation. People are constipated and then they're they're kind of straining. That causes them to have the hemorrhoid. And a lot of times for treatments for hemorrhoids, it's something as simple as a sitz bath, where they basically are going to put Epsom salts in a bathtub and then just kind of sit in there for a little while. There's different types of hemorrhoid creams that they might try. Sometimes, depending on how severe it is, they might have to go into the doctor's office where they lance it so it can drain. So, all right. So these are the other types of hernias, which a hernia is basically any part of the intestine that can go through a muscle. So this here, it's going through the abdominal muscle. So you have an umbilical hernia, which they call it that because it's in your umbilical area, and then an inguinal hernia, and then a femoral hernia. So inguinal hernias are kind of more common in males. Again, not sure exactly why, but it forms in the groin area. So it's part of the intestines that push through part of the muscle in that area. It's essentially what a hernia is. And these usually do require surgery. Every once in a while, a doctor can just like push it back in, but most of the time, at some point, it's going to just come right back out. So it's a lot of times it's due to like weakened muscles in that area. So, if you are working on your abs and stuff, then you're probably not going to end up having a hernia because you have really strong muscles. So,
Okay, wait, it's just weak muscle that cause it, and what's the muscle and inflamed? What's that?
I mean, basically, it's just that the muscle itself is weak, and you have, your intestines are kind of pushed up against your muscle, and then at some point, it like just kind of shoves through that muscle. But those particular areas are where, you have more muscle weakness. So that's why, it's like in this area, it's even if you were like working out and had like a six pack and all that kind of stuff, in this area, it's kind of hard to like strengthen your muscles. So
I want to find out where that.
Wait, Caitlin, what do they do during the surgery? Do they just like remove the muscle? Is that even?
depending, so if it's strangulated, meaning like it pushed through a muscle and then there's so much like that opening is cutting off circulation to that part of their intestines. Depending on how long that's been like that, if that area is dead, they basically have to cut it out and then reconnect their intestines somewhere.
Is the internal organ mostly the intestines, or is it only the intestines?
It's only the intestines.
Mm.
So, anyways, I'm sorry, Tequila. So, what was your question again?
No, you answered.
Okay, I just wanted to make sure. Okay. Okay, so another common disease here, I'm just going to kind of you guys can read these different slides. So I'm going to go through a couple other ones in here too. So that way we go over some treatments. And I'm going to post this PowerPoint actually is already posted in your guys' course. So again, this is something you guys can go through to review. I just want to make sure you guys know about treatments as well. But most of the time, most common symptoms you're going to see in a patient is abdominal pain, nausea, vomiting, heartburn or indigestion. Not so often will they have like a fever, but then they will notice, of course, if they have a hernia. Like they're going to notice, like, I have a sudden lump coming out somewhere. Usually they have some pain associated with it. Not always, like sometimes it's kind of like, oh, I just noticed that there's a lump there, but it doesn't hurt, so it's fine. But like the longer they have like that hernia, that's why sometimes people like wait so long to go see a doctor because they're just kind of like, oh, it doesn't hurt or anything. So I mean, I guess I'll just leave it. Um, but eventually like it will just keep getting worse. And then at some point it's gonna really hurt and then they're gonna need to have surgery, but then their surgeon's backed up like, a week or two, and it's not technically an emergency because it's not cutting off circulation to it yet. So you're just kind of waiting, which kind of sucks. Yeah. And you're in pain. So, I mean, that kind of is not fun. So, okay. So let's go over different types of tests. Let me go through here and what we do. So of course, for the medical assistant, when we get calls from patients, we're going to be asking them those different questions when they call in saying they're having some type of GI issue. So again, what we just went over, abdominal pain, nausea, vomiting. My gosh, I don't know why I can't say that. Constipation, diarrhea. Sometimes they might have a fever. We still want to ask that kind of thing too. I would also like to add to this part of the screening questions is asking where the pain is, because it does make a difference if it's lower right abdominal pain or upper left abdominal pain. Because if they're having lower right abdominal pain, the next question you want to ask is if they still have their appendix, because that could be just, a symptom of appendicitis. If they're having upper left abdominal pain, they might have gallstones. So
Lower left,
lower right
lower right is
and upper left. Lower right is where your appendix is. Upper left is where your liver and gallbladder. But we want to get as much information from the patient for the provider so we can go to them and we're like, hey, instead of going to them and they're like, oh, they said they had abdominal pain. We want to be more specific than that. So we would then make sure that the doctor knows, it's like, hey, they've been having upper left abdominal pain for 2 weeks. Any other things that they give you. So they're like, they have had heartburn along with it, or they haven't had that with it, no other symptoms or whatever other symptoms they might have with it. So you just want to get as much information as possible. So, and then, of course, that's what, knowing where the different organs are, because then we want to ask them those kind of questions, because that just helps the doctor kind of determine more so. But so there's different types of diagnostic procedures they do to test patients for various disorders. So ultrasounds they might do to check for gallstones. Colonoscopies they do on patients once they reach above 60. They'll usually start doing colonoscopies every 10 years. So not something super often unless they notice something abnormal. So oftentimes it's like a screening tool, but unless someone has certain symptoms, then they might do a colonoscopy.
every 10 years after what age?
60?
And what did it start?
What's that?
When do you start getting called?
When you're 60.
You start getting
Yes,
You know
so
what?
they're kind of like, they're like a screening tool to see for like colon cancer, but if someone is having certain symptoms, like they have blood in their stool, then they might just do a colonoscopy. So, and if they notice like when they do that, that there's like polyps or something, they'll usually have them do it more frequently. So that way they can check up and make sure that there isn't any cancer developing. So it changes when they have symptoms. But another thing that they'll do to test for GI issues is most commonly what they do is stool tests. So this could be where they are checking for E. coli, they're checking for ova and parasites, meaning like, you know, when they, if they develop food poisoning, if it's being caused because whatever it is that they ate then contains some sort of parasite in it. So they'll do these different types of tests, and they'll also test for blood in their stool too, because if they might have a GI bleed somewhere within their intestines that we want to make sure, you know, it's not just caused by like a hemorrhoid, so that it is coming from somewhere in the intestines, so that way they can figure out where it's at and then cauterize that area is usually what they'll do in surgery. But they'll usually send patients home with a kit that they will, you know, well, we are the ones that are actually going to give instructions and put this kit together. But where the patient actually takes the containers home, and then we want to let them know, you know, how much, what to what degree, how much we need, how to collect it, and everything. Because the containers will come with like a little liquid in it, and it actually has kind of like a scoop inside the lid, but it's up to a line that we want to make sure that they fill it to, because then we need to make sure we have enough to test. And it could just be, you know, the doctor does a stool smear on a card, and then they use this developer that shows if there is blood or not. So, but we give those things to the patient. So an alternative to a colonoscopy, sometimes that patients can do, is something called Cologuard. So this is an at-home test that they will do, and it's like a whole kit that gets sent to the patient from Cologuard. So it has all the instructions and everything, you know, what the patient needs to do. But it's basically them obtaining a stool sample and sending it, they'll put it in the little container, or whichever way it is that they want them to do this. Sometimes it could be that they need to just smear in 2 spots. They collect it from 2 different areas of the sample and then smear in 2 spots, and then they use the developer. But I can't remember exactly how Cologuard works, because there's other types of testing that's similar to Cologuard that work a little differently. But I mean, of course, that company, like when they go through Cologuard, it has a whole kit of instructions of what they need to do. It's not a bad idea for you to get familiar with the instructions on whatever your office might use, if it's different from Cologuard. So that way you can kind of know, you know, tell a patient, help them out, because they might not have the best eyesight or whatnot. So, and the colonoscopy, this is just kind of what it looks like, is they use this flexible scope that has a light and a camera at the end of it. So they'll go in and kind of snake through, you know, their intestines and then see, you know, if they have any polyps or anything. They can see them there, and they'll usually, if they see any polyps, they'll usually go ahead and remove them and then send them out to be tested to microbiology to see if they're cancerous or not. So, okay. So some treatments that they'll usually give to patients are antacids, laxatives if they are having constipation, things, proton pump inhibitors, which treat GERD, is basically another word for heartburn. And those also help with ulcers too. So, but the doctor might prescribe certain medications depending on what issue they're having and to what severity. And there's also, besides laxatives, there's also ones that help with people who are having diarrhea too. So, I mean, there's both of those. So, that's pretty much it for that. But the main thing with this gastroenterology, when you see a patient, you just want to make sure you ask the questions to them so you can get as much information to the provider. And of course, I mean, pretty much anywhere you work, you're going to go over their allergies and medication list. But making sure, checking their symptoms and then going over what, if they've already had certain treatments done. And then making sure sometimes you might have to assist in the colonoscopy or ultrasound or whatever test it is. And then familiarizing yourself with instructions on, like if you're sending a patient home with testing they need to complete. And the reason we send them home, well, obviously because, I mean, you can't always, have bowel movement on command, obviously. So there's that part of it, but also because if they do have some type of illness, depending on what it is, sometimes they're transmitted through the air. But if the patient already has it and they're collecting their own sample, then they're not going to pass it to somebody else. Once they get it to the lab, they have like a vented hood that like sucks the air up, so they're not going to, absorb any of that. But we don't want to have the stool sample and then us transfer it to the container, because then there's a potential that you could become sick. So
The only CMA was checking symptoms, asking questions over the phone. Help patient with instructions and answer questions throughout the sample.
Yeah.
And associated.
Yes, but you definitely want to make sure too, like the different types of disorders, because that will help you to know like what question to ask next. So, do you have any questions, Tahila?
I did. So on one of the slides, it was like, don't get any urine or toilet paper in the sample.
Yeah.
Well, how do you do that? Do they make them poop in like a little container and then put the sample in, or I don't know. I'm just confused.
So usually what we do is we send them home with, it looks kind of like a hat. That's actually what we call it, is a hat. I'll show you what that looks like. Hold on. Let me open up I'm gonna go to my home screen. Sorry. But that's what we call it, is a hat, and it's a thing you're gonna put in your toilet that you basically want to make sure that you put towards the back, so that way, you are collecting the stool. So I'm just gonna say it's a urine hat, because I mean it's the same thing, but they basically. So instead of putting it in the front here, they would put it in the back part of here. So that way they're collecting their stool instead.
Yeah.
So, they're just trying it. Sometimes it's really hard to not get urine mixed in there, especially for females. But they just want to make sure too that they tell them to not get toilet paper, and like when they do wipe afterwards and everything, to make sure they put it in the toilet, not in the container. So
Okay. I was so confused. It's like poop in the toilet and then like scoop it out with a spoon or something.
oh yeah, no, not in the water. It's we usually give them this little hat that they collected in.
Okay.
Yeah, that would be interesting.
Yeah.
So
Yeah, I think that was it. Oh, and I was also wondering if you were gonna post any new module weekly thingy.
yeah, I can do that for you.
Thank you.
Yeah, no problem. All right. Well, have a good rest of your day.
You too.
All right, talk to you later.
Bye.
Bye.